This is Chapter 20, Rehabilitation of Groin, Hip, and Thigh Injuries. The first slide contains diagrams of the bony and contractile tissue of the hip. As you remember from lower eval class, this is quite a muscular area. The bony articulation between the acetabulum on the pelvis and the femoral head is also quite secure. However, the ball and socket shape, plus the femoral neck offsetting the femoral shaft, make this joint quite mobile. Unfortunately, as we may have experienced in clinical practice or firsthand, the muscles have to cooperate with the motion. That is a big problem for many patients. These bony landmark muscles in the muscle OIANs are a little hazy. Please make sure to review your lower eval and anatomy notes, as I will continue to emphasize being good at evaluation will make you good at rehab. Another anatomical considerations I will discuss briefly are the angle of inclination and angle of torsion. This is the angle of the femoral neck relative to the shaft in the femoral plane. The angle of inclination is impossible to determine without an X-ray. Normal angle of inclination is approximately 125 degrees. A greater angle than that is coxa valga. With this, you will find decreased shear force on the femoral neck, decreased hip stability because the femoral head is shallower in the acetabulum, and genuvarum at the knee. Angle of inclination less than 125 degrees is known as coxa vara. With this, you will find increased shear force on the femoral neck, increased hip stability, and genuvalgum at the knee. The angle of torsion is the angle of the femoral neck in relation to the axis of the femoral condyles in the transverse plane. Normal angle of torsion is about 15 degrees. Increased angle of torsion is known as introversion. This leads to decreased joint stability, increased femoral internal rotation, and results in a toe-in gait. Decreased angle of torsion is retroversion. This leads to increased joint stability, increased femoral external rotation, and results in a toe-out gait. Craig's test, which is linked at the bottom of the page, can give you a decent idea of the angle of torsion. Clinically, changes in both these angles could cause changes in rotation of the femoral head within the acetabulum that predispose the patient to chronic injuries such as stress fractures and overuse hip injuries, as well as acute injuries such as hip subluxation and labral tear. If I have not driven home the point that these two slides are important by now, I'm not sure I can. These last two slides detail various conditions that you'll see, both acute and chronic, in the hip, groin, and thigh area. The first few are bony issues. An iliac crest contusion is commonly known as what? An ASIS or PSIS joint trauma injury is somewhat common because they are pretty prominent, especially in a thin individual. Some of you may have dealt with this injury yourself. As far as rehab is concerned, there's not too much to do after getting the symptoms to subside. After that point, progress is tolerated just like anything else. This will probably be an abbreviated time out of activity after you get the inflammation calmed down, which requires balancing the inflammation and the activity allowed. It will be more delicate with the iliac crest or ASIS contusion compared to PSIS. Why? The answer is in the other injuries to the ASIS. An avulsion means what that was happening. The bone has been pulled away by another structure. In this case, it was muscle. As all of you know from applied, there are many muscles that connect into the pelvis and there is bony landmark on the anterior side. These muscles are constantly firing and in motion, with stress on those bony attachments. In chronic situations, these become apophysitis in a microtrauma situation, or avulsions in a macrotrauma situation. However, no muscles connect to the PSIS area, meaning there is no way an avulsion or apophysitis can occur. Quad contusions are almost like any other contusion. The one thing to note is that with the large muscle mass in that area, you need to be sure that a contusion does not continue to bleed in a stationary muscle. For example, if you have a patient who sustains a quad contusion in an evening event, always make sure that they sleep with the muscle on stretch. That keeps fluid from creeping within the muscle. Minimizing the edema is paramount for treating this injury. Quick terminology note is that the rehab book uses myositis ossificans, while the evaluation book uses heterotopic ossification. Either is a complication or a continued irritation of the quad contusion or quad strain that leads to calcification of the damaged tissue. These can come about from mismanaged injuries, so be sure that you do not see the manifestations of these 3 to 6 weeks after initial trauma. We see lots of quad, hamstring, hip flexor, and groin strains in the athletic world. Most times the clinician straddles the line of participation without deciding negative outcomes in these injuries. We will discuss these in more detail during class. The slide also lists multiple types of avulsion fractures that can happen in the hip. These are not too common, but just understand what you would see in an eval that would differentiate these from a moderate strain. Femur fractures are listed on the slide, even though many you will see it in an athletic world are the stress microtrauma. There can be acute fractures to the femur. What part of the femur would be most vulnerable? The femoral shaft is said to be stronger than concrete, so it would be incorrect to say the shaft. The acetabular lesion is something that you see when you finally get an MRI after treating a patient for months for what you thought was a bursitis or tendonitis. Missing this happens quite a bit, believe it or not. And lastly, hip dislocation is an emergent situation. Rehab will be a slow process after the hip is stabilized with prolonged immobilization. For those of you who will be working with a more general population in your clinical careers, you will hear the term sciatica quite a bit. This is kind of a catch-all for any neurological pain felt in the posterior thigh into the knee or the lower leg. As a clinician, you need to be able to figure out why these symptoms are appearing. A tight piriformis, acute trauma, or pathology of the hamstrings or low back can all be culprits. Many times, it is a combination of 2 or more of those reasons. Finding a reason will help improve the symptoms for you. The 3 bursitis conditions listed are all results of microtrauma. Earlopectineal bursitis is the least common of the 3 by far. Hopefully you are all familiar with where trochanteric and ischial bursitis are common. Snapping hip syndrome is usually a result of trochanteric bursitis, which the IT band snaps over that bony prominence. The early source hitting the earlopectineal eminence may also create that sensation in the anterior hip. As it is a microtrauma situation like the various bursitis cases, treatment and rehab will look very similar. Athletic pubalgia or sports hernia do not have a full detailed description with empirical evidence in the literature. It is believed that this injury is a weakening of the posterior inguinal wall due to repetitive stress in that area. Osteitis pubis presents in a similar fashion to sports hernia with deep-seated pain in the groin area. They will specifically be tender on the pubic bone. Activity with any forceful direction changes can create this pathology. The last bullet discusses femoral stress fractures. We have alluded to this already, and pages 622 through 624 discuss a protocol for treatment and rehab of this condition. One population this is seen infrequently are enlisted soldiers in boot camp. Any idea why? Please come to class ready to discuss these conditions and everything around hip rehab.